Hi everyone. Hi everyone. My name is Jillian Graham.
My name is Graham&Carmody.
And today we're going to be discussing earlier intervention over the years from the 1910s to present day. We will be discussing some interesting trends and research that we found and talk about how early intervention got to be the critical practice area that it is today. So during the 1900s, nurses were the professionals who were typically caring for the young infants. Research in basic areas such as dressing, sleeping, and eating began to emerge to guide what is typical in infants and young children. However, occupational therapy was just emerging, so this research was being done primarily by other professionals. As the 1920s emerged, OT research was increasingly becoming more popular, and it was said that patients who have been given some form of interesting occupation are happier and recover quicker. The importance of play was also being realized, and for young infants from a few months old to 2 years, a soft red ball swinging on the side of their crib was used to engage the child. This was seen as the first lesson in concentration. In addition to all of this, it was recognized that cognitive interventions are not just for those with a cognitive disability. During the 1930s, OT's value as a skilled profession was being realized. It was stated that skills in arts and crafts are necessary, but should be in addition to a thorough grounding in psychology, a good knowledge of mental disease, and a large amount of common sense, coupled with an ability to approach patients in the right way. The polio epidemic resulted in many children hospitalized and in need of OT. Children with polio spent sometimes months in a hospital bed, so occupational activities were formed and adaptations were made to the typical type of craft work to allow children with special disabilities to participate. During the 1940s, interviewing showed the emergence of client-centered practice and use of assessment. Occupational therapists were utilized to provide an optimal emotional hospital environment for the infant and child. OTs would interview the parents and become acquainted with the children at admission, affording the therapist an opportunity to learn the habits, background, special preferences, and talents of the child. This information was then recorded and attached to the patient's chart. Focused treatment for conditions such as cerebral palsy was also seen during this time period. Treatment for CP differed from other conditions. Typical treatment during this time was to have the patients focus on the activity he or she is performing and to forget about the joint or muscle group being treated. It was realized that working with children with CP is extremely interesting because no two children have identical disabilities. And as therapists, the importance of being able to differentiate between spasticity and athetosis was realized. Due to this, it was impossible to lay down set rules for the use of arts and crafts and the desirable sequence of these crafts. At the time of the 1950s, OT continued to establish itself as an integral part of the medical team and worked to further establish and define the profession by becoming members of the research team. It was further understood that the occupational therapist requires a detailed knowledge of the normal growth and development of children and a knowledge of the various levels of achievement due to the fact that children are constantly growing, developing, and changing. Toys and play that is specific to a condition or disability was also seen during this time. It was said that a blind child must be provided with toys with auditory and tactile stimuli to develop their interests and skills, rather than a typical toy with bright colors and lights that are typically used for children with normal vision. For preschool children with CP, toys such as a flower pegboard, a four-sided wooden Christmas tree, and a rabbit puzzle were used to address the specific needs of a child with CP. These toys address reach, grasp, and release patterns, shoulder abduction, forward flexion, elbow extension, among a few other things, as well as facial relations when completing the puzzle. During the 1960s, it was realized that home programming is a comprehensive approach to habilitation and rehab for children. OTs went into the home during this time and began teaching parents everything they knew specific to their child's diagnosis and how it applies to their child individually. It was believed that parents are in the best position to influence their child's daily and social environments for the atypical child. It was also recognized that the early years of life are the foundation of development, therefore treatment is essential as soon as atypical development in a child is recognized. During the 60s, it was realized that early intervention is needed as soon as a child is detected as atypical, and occupational therapists must encourage the parents to engage with their child.
As the 1970s progressed, OT was defined as one's participation in selected tasks to restore, reinforce, and enhance participation, facilitating learning, of skills and functions essential for adaptation and productivity. However, the primary focus of occupational therapy is the development of adaptive skills and one's improved performance. When a child receives early intervention, they are seen to have a significant growth and better outcomes in school. Occupational therapists can make an important contribution with pediatric children in a playroom by screening children who present with developmental delays, and children can be referred for additional testing and evaluations. Once treatment is permitted for a child who needs services, an occupational therapist can make intervention plans to help a child perform at their optimum level. As the 1980s progressed, it was proposed an intervention approach that is culturally relevant, multidisciplinary, and family-centered in nature is the one way of redefining OT strategy and contribution in early intervention settings. Early intervention services in the home, allowing therapists to have an increased control and flexibility, allowing therapists to adapt treatment styles and adjust the environment for their client. The family-centered framework was also mentioned during this time period for early intervention and was developed from the concepts of the model of human occupation and from developmental literature on play. In this framework, it was stated that parents have a major effect on play behavior and play environment. Therefore, therapists may consider the parent's interests, routines, values, goals, and skills when designing intervention strategies for the infant. Specialized practice in the NICU was also emerging practice during this time period. Two approaches in the NICU were the environmental approach and the clinical approach. The environmental approach focuses on creating a systematic plan for organizing the infant's environment. It recognizes the infant's sensorily deprived due to the nature of premature birth, yet is also being sensorily bombarded due to the harsh nature of the medical intervention in the NICU. It is understood that during this time, the infants need gradual sensory input and handling techniques that are specific to the infant's individual responses. The clinical approach addresses the observable need for infants, such as deviations in muscle tones or organized or disorganized behavior. The role of the therapist in alleviating the parents' fears in interacting or holding their infant by educating them and handling the infant and observing their reactions was emphasized during this period as well. In the early 1990s, early intervention practices continued to establish itself. An emphasis on early intervention services for children with developmental disabilities continued to emerge, as well as the importance of family-centered care. At the time, early intervention services were not thoroughly researched yet. In this decade, the importance of getting children with developmental disabilities such as autism spectrum disorder and CP services as soon as possible was ideal. Focusing on fostering parent-child interactions rather than addressing specific skills of development in the child was seen as essential in providing family-centered services. In a study looking at the effect of the OT intervention on mothers of children with CP, it was seen by researchers that communication between therapists and mothers is an important issue in early intervention childhood services. The study further emphasized the importance of family-centered care and discussed the regular communication and active listening being an essential part of therapy as well, because that will form a strong relationship and will be effective in changing the child in a better way. Interdisciplinary collaboration between occupational therapists and other professionals was also seen to be important to the child's success. As the early 2000s emerged, healthcare providers recognized the critical role of parental involvement in therapy. For children receiving early intervention services, as well as the importance of a child receiving services in their natural environment. Caregivers can translate the intervention into their natural environment involving their daily routines and activities. These strategies learned will be implemented daily into the child's natural environment, which is ideal for the child's development and growth. It was seen by researchers that occupational therapists highly value the parent-child relationship and focused on these relationships during their therapy. Early intervention programs have been shown to improve development outcomes, strengthen parent-child interactions, provide a supportive family environment, and it was seen that parents and caregivers are an important role and involved with early intervention services, as strategies taught in the session will further their development and their competence, as well as their ability to meet their kids' needs. During the early 2010s, the demand increased for early intervention services because the increased prevalence of developmental disability, such as CP, child abuse, prematurity, prenatal substance exposures, and in addition, an increased prevalence in ASD, learning disabilities, and ADHD. Another thing that was seen during this time period was the use of telehealth. Telehealth was being used as a service delivery model for children that lived in rural areas and had limited access to services due to personnel shortages. Telehealth services allow occupational therapists to reach more clients, save time, and save within their travel costs. This is also an effective way that has been seen through COVID-19 as a service delivery model to their clients. When treating a child, it is important to be aware of their culture. Just like in any other setting, cultural competence needs to be considered when working with children who receive early intervention services. Occupational therapists need to support clients in their culturally relevant activities and use intervention approaches that are culturally relevant to them and their family. All in all, early intervention continues to emerge into an important practice area. The need for early intervention will likely continue to increase, and as early intervention services become increasingly prevalent with different populations and cultures, it's important for occupational therapists to continue to develop cultural competence. Thank you for listening to our historical analysis. We hope you enjoyed our analysis on early intervention occupational therapy practice, and please contact us at the emails on the bottom left corner if you have any questions on the presentation.
Thank you.
Thank you.